Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today we are focusing on a pathology that is, well, technically benign, yet it causes a level of morbidity completely disproportionate to its size. We're talking about the anal fissure.
It's a fascinating condition, It sits right at that intersection of really simple mechanics and surprisingly complex physiology.
Yeah.
You have this tiny linear tear, sometimes it's no bigger than a few millimeters, that can just completely debilitate a patient.
And while the general public might just see this as a tear, our mission today is really for the surgeons and clinicians listening in. We know you can identify a fissure. The goal of this deep dive is to move past that textbook definition.
Mm-hmm.
We want to get into the granular management. We're going to unpack the pathophysiology, specifically this whole concept of the vicious cycle, and then walk through the entire escalation ladder, from conservative care right up to the nuances of, say, a tailored sphincterotomy.
Exactly. The big shift we need to make today is conceptual.
Mm-hmm.
We have to stop looking at the fissure as just a wound that needs stitching and start seeing it as a hemodynamic crisis. It's all about pressure. If you don't treat the hypertonia and the ischemia, you are just chasing symptoms. You're not providing a cure.
Okay, before we dive into that hemodynamic argument, I do have to drop our mandatory disclaimer. Everything we're discussing today is for informational and reference purposes only. Clinical guidelines, they vary by region, by institution, so please always follow your local protocols in your actual practice.
That's always good to keep in mind. All medicine is local.
So let's get right into the mechanics. If I get a small cut on my finger, or maybe a mucosal injury in my mouth, it heals up pretty quickly. The anal canal is highly vascular, so why do these fissures persist for months? What makes this area so uniquely prone to not healing?
It all comes down to a very specific anatomical vulnerability. You have the initial trauma, right? Usually the passage of hard stool, which creates the tear in the anoderm. But the persistence of that tear, that's driven by the internal anal sphincter.
That's the involuntary smooth muscle layer, the one you can't control.
Correct. So when that anoderm is torn, the pain triggers a reflex spasm in that internal sphincter. This isn't something the patient can just, relax. That spasm causes the resting anal pressure to skyrocket.
Okay.
And here's the critical physiological mismatch. The blood supply to the posterior midline of the anal canal is essentially a watershed zone. It's precarious even at the best of times.
So when the pressure from that spasm goes up, it's literally squeezing the capillaries shut. Is that what's happening?
That's it. You get a localized ischemia right at the posterior commissure.
Yeah.
The tissue desperately wants to heal, but it's being starved of oxygen and nutrients by the very muscle that's trying to protect it.
So the ischemia prevents healing. The open wound causes pain.
The pain causes more spasm, and the pressure stays high. That is the vicious cycle.
Which explains why the pain is so characteristic. It's not just the pain during defecation. It's the aftermath that's so telling.
The passing broken glass description is, well, it's classic. But the real diagnostic pearl is the duration. The pain persists for minutes, sometimes for hours, after they've had a bowel movement. That lingering pain is the clinical sign of the spasm we just talked about.
And this spirals into a behavioral loop that just makes everything worse. Stool withholding.
It's a completely natural reaction to fear, isn't it? The patient knows it's going to hurt, so they hold on. Of course, the stool then sits in the rectum. More water is reabsorbed. It becomes harder, larger.
And when they finally go, it causes even more trauma. It just re-tears the wound.
Exactly. Every few days.
Okay, let's talk diagnosis. We have a lot of residents, a lot of junior doctors listening. There's a very strong do not attached to the acute presentation of this condition.
Yes. And this is critical. If the history is screaming fissure, sharp pain, bright red blood on the paper, that lingering ache, do not perform a digital rectal exam. And please, do not use a rigid proctoscope in the acute setting.
It feels a little counterintuitive, to not examine the area you're treating, but the logic is all about pain control. And trust.
It's about trust and utility. A DRE in an acute fissure patient is just excruciating. You will lose their compliance immediately, and frankly, it rarely adds any diagnostic value in that acute phase.
So what's the move?
You can diagnose this with gentle visual inspection. Just gently separate the buttocks. 90% of these will be visible right there, posterior midline.
And if you can't see it, maybe the patient is too guarded.
Then you treat based on the history. Or you plan for an exam under anesthesia later on. But forcing a finger in there is a mistake. A big one.
You mentioned 90% are posterior midline. What if we see a fissure somewhere else, say laterally? Or if there are multiple fissures?
That is a massive red flag.
Mm-hmm.
A lateral fissure is not a normal fissure until you've proven otherwise. You have to broaden your differential immediately.
So you're thinking Crohn's disease?
Crohn's, HIV, TB, syphilis, even malignancy. Standard fissures are posterior and sometimes anterior in women. Anything else demands a full workup.
Okay, let's move to the management algorithm. We've established the diagnosis, hopefully just visually. We know the pathophysiology is pressure-based. The patient is in your clinic. Step 1 is the conservative stuff.
And it works. You have to remember that. For acute fissures, so those present less than 6 weeks, about half of them will heal just by normalizing the stool. We're talking high fiber, aggressive hydration, and stool softeners like macrogalls.
The sources also really emphasize checking the patient's current med list.
Oh, absolutely. If they're on opioids for the pain, which happens surprisingly often, you are fighting a losing battle against opioid-induced constipation. You have to get them off any constipating agents.
And what about sitz baths? They sound a bit old-fashioned, but I guess the mechanism checks out.
It's simple thermodynamics, really. Warm water helps relax the smooth muscle of the internal sphincter. It improves blood flow. It's a very low-tech way to attack that ischemia component of the cycle.
So diet and baths are the baseline. But let's say the patient comes back at the 6-week mark. The pain is still there. Fissure hasn't closed. Now we have to escalate to what is effectively a chemical sphincterotomy.
This is where we start using pharmacology to do what a scalpel would do later, which is lower that resting pressure. For a long, long time, the standard was topical nitrates, specifically glycerol trinitrate or GTN.
But clinically, GTN comes with some significant baggage.
It does. I mean, it's a potent vasodilator, which is great for the fissure, but systemic absorption is so common. The nitrate headache is a real barrier to care. You'll have patients who apply the cream, get a blinding headache, and then just stop using it. Compliance is a huge issue.
Which has really led to a big shift toward calcium channel blockers.
Right. Topical diltiazem or nifedipine. In many specialized colorectal units, this has effectively replaced GTN as the first-line pharmacological agent.
Is the efficacy really comparable?
The data suggests the healing rates are very similar. They're looking at generally in the 50 to 70% range for chronic fissures. But the side effect profile is just vastly superior. You don't get those debilitating headaches.
So even if the theoretical efficacy is the same, the real-world efficacy might be higher just because patients actually finish the course of treatment.
Precisely. If they don't use the cream, it can't work. It's that simple.
Okay, so we failed conservative management. We failed topical therapy. The fissure is now truly chronic. Before we scrub in, there's this intermediate step, botulinum toxin.
Botox is a fascinating tool here. What we're doing is injecting it directly into the internal anal sphincter to cause a chemical denervation. It basically paralyzes the muscle, prevents that spasm, and drops the resting pressure.
And how long does that effect last?
It's transient, usually around 3 to 4 months. And that's kind of the sweet spot. It gives the fissure plenty of time to heal in a low-pressure environment, but the muscle function eventually returns. Healing rate's pretty decent, around 60 to 80%.
So is Botox a viable alternative to surgery for everyone? Or is there a specific type of patient where this is really the preferred option?
I wouldn't call it the standard for everyone. It's really more of a bridge therapy or a salvage option for very high-risk patients. Think about a multiparous woman with a history of obstetric tears or an elderly patient with weak baseline continence.
So patients where you're terrified of cutting any muscle.
Exactly. If you cut the sphincter in someone who is already borderline incontinent, you might fix their fissure, but leave them wearing diapers for life. Botox offers a way to lower the pressure with virtually zero risk of permanent incontinence. They might get some transient leakage, but it always goes away.
That brings us to the surgical gold standard. The patient has failed meds, maybe failed Botox, or they just want a definitive fix. We're talking about lateral internal sphincterotomy, LIS.
LIS is still the gold standard for a reason. When you look at the randomized trials, the healing rates are just. They're consistently between 88 and 100%. Recurrence is incredibly rare, usually less than 10%. Mechanically, it just works. It creates a permanent reduction in that resting anal pressure.
The procedure itself involves dividing the internal sphincter. There's been some debate over open versus closed techniques. Looking at the source material, it seems that debate is largely academic at this point.
It is, yeah. The open technique involves making an incision to see the muscle. The closed technique is done more blindly with a blade in the inner sphincteric plane. The outcomes are statistically equivalent. It really just comes down to surgeon preference and training.
Okay, but there is a nuance in how much muscle gets divided that seems absolutely critical, this concept of a tailored LIS.
This is probably the most important technical takeaway for the surgeons listening. Historically, the teaching was often to divide the internal sphincter all the way up to the dentate line. We now know that's just overkill. It's dangerous.
Dangerous in terms of continence, I assume?
Yes. Dividing that much muscle significantly increases the rates of incontinence to flatus and even stool. The modern evidence-based approach is tailored LIS. You only divide the muscle up to the apex of the fissure itself.
So you're using the pathology, the tear itself, to guide the extent of your myotomy.
Correct. You limit the division to the extent of the tear. And the trials comparing tailored versus traditional LIS are incredible. They show that the healing rates are identical, still over 90%, but the incontinence rates, they just plummet. We're talking about dropping from maybe 11% incontinence in untailored groups down to around 2% in tailored groups.
Wow, that's a career-saving difference. It really sounds like the tailored approach should be the only approach.
It absolutely should be. There's really no justification for an extensive sphincterotomy in the modern era.
But even with a tailored cut, there are still those patients where any cutting is too risky. We touched on this with Botox, the women with obstetric injuries, patients with Crohn's, the elderly. If Botox fails in these groups, are they just out of options?
No, but we have to completely switch strategies. We move away from relaxing the sphincter, and we move toward covering the defect. This is where sphincter steering options come in, specifically the advancement flap.
And this is a much more technically demanding procedure. Can you walk us through the concept?
It's essentially plastic surgery in the anal canal.
Yeah.
You start with a fissurectomy, so you're excising the chronic fissure edges in that sentinel pile to get back to fresh bleeding tissue. But instead of cutting the muscle underneath to relieve pressure, you mobilize a flap of healthy, vascularized anoderm or skin.
Usually like a VY advancement or a house flap.
Exactly. You advance this healthy tissue over the defect and suture it down. You're literally bringing a fresh blood supply to that ischemic zone, but you're doing it without compromising the sphincter's integrity at all.
The trade-off, of course, being that you aren't actually fixing the underlying pressure problem.
That's the catch. You are relying on this healthy tissue to bridge the gap despite the high pressure. Healing can be slower, and the technical failure rate is a bit higher than LIS, but the incontinence rate is the key metric here. In most series, it's reported between 0 and maybe 6%.
So for that high-risk patient, you're accepting a slightly lower chance of healing or a more complex recovery, but in exchange, you're preserving their continence.
That is the calculation. A meta-analysis confirmed this. Significantly lower incontinence with flaps compared to LIS. If you have a patient who cannot afford to lose even a sliver of sphincter tone, the flap is your safety net.
Let's talk about post-op. We've done the LIS or the flap. The patient is healed. Is that the end of the story?
It really shouldn't be, and this is a common pitfall. The surgery fixes the anatomy, but it doesn't fix the lifestyle that likely caused the fissure in the first place.
So if they go right back to a low-fiber diet and straining,
they can tear right through the scar tissue or develop a fissure in a completely new location. Maintenance therapy is crucial. Patients need to understand that high fiber and hydration, these are likely lifelong commitments for them.
And if we do see a recurrence, say 6 months down the line, the patient is back with pain.
You have to take a step back. First, check compliance. Are they straining again? But second, and more importantly, you have to reconsider your differential diagnosis. Is this actually Crohn's disease that we missed the first time? Could it be a malignancy?
It's a moment to pause and recalibrate, not just rush back to the operating room.
Exactly. If you keep operating on a non-healing wound without understanding the true etiology, you're going to cause harm.
This has been a really comprehensive review. Let's try to synthesize this into a deep dive protocol for everyone listening.
Let's boil it down. 1. Acute fissures are common. Don't do a DRE. Treat them conservatively with fiber, fluids, sitz baths, and get them off opioids. 2. If it becomes chronic, you have to recognize it's a pressure and ischemia problem. Start with chemical sphincterotomy. The pearl here is to prefer calcium channel blockers like diltiazem over the nitrates to avoid the headache and just get better compliance.
Step 3.
If medical management fails, assess the risk. If the patient have good continence and standard anatomy, a tailored lateral internal sphincterotomy is the gold standard. The key word is tailored. Cut only to the apex.
And step 4 for those complex cases.
If the patient is high risk, so obstetric history, IBD, Elderly do not cut the muscle. Use Botox as a bridge, or if surgery is absolutely needed, you use a sphincter-sparing advancement flap to cover that defect without compromising control.
Simple, logical, and it really prioritizes the patient's long-term quality of life.
It's all about matching the weapon to the target. You don't need a cannon for everything.
Well, that wraps up our deep dive on anal fissures. We really hope this moves the needle for you in the clinic and in the OR.
And remember, if you liked this content, please don't forget to share it with at least one of your colleagues or friends. Send it to that resident who is still reaching for the GTN first.
Help us spread the word. And be sure to check out our YouTube channel and our other social media pages. We'll try to get some diagrams of the tailored LIS versus the traditional LIS up there, just for a visual reference.
And we'll leave you with one final thought. We often view the anal fissure as just a wounded tear that needs to be stitched or glued. But in reality, it is a hemodynamic problem. It's a battle between pressure and flow. Success lies in treating the invisible pressure, not just the visible tear.
Treat the pressure, heal the patient. Thanks for listening, everyone. We'll see you on the next deep dive.
Goodbye.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.